Good morning, all the dear delegates of this eNeo course. This eNeo course has been designed for office-based pediatricians who have an interest in neonatology because as a team, Delhi IAP, and as an individual, I appreciate that every pediatrician does neonatal work at some stage. And it is important to upgrade their knowledge, even if they may not be doing core neonatology. But that is how this course has been spanning over 15 sessions. Today, we are in the ninth session, which is on feeding challenges in a newborn, where we are going to discuss what are the challenges faced by an office-based pediatrician as far as feeding of a term and preterm is concerned. So before I open the session, we have Dr. Alok Bhandari, who is the President IAP Delhi. So I request Dr. Alok Bhandari to say a few words and then we start with the proceedings of the day. Dr. Alok, sir.
सॉरी डियर, मैं थोड़ा सा लेट हो गया नेटवर्क इशू की वजह से.
No problem.
गुड मॉर्निंग
You're in
फ्रेंड्स.
time.
नहीं, डॉक्टर अशोक सर आ गए हैं. पी अशोक
हाँ
सर.
जी, he is there. He is there.
I'm here.
क्योंकि he is braving all rains in Kerala and he is there and we welcome him on this local monsoon session of neonatology, and it's a great feeling to be here with us and welcome everybody. And डॉक्टर अशोक की बात हो गई, बाकी उनका
नहीं अभी करनी है, अभी सभी का इंट्रोड्यूस करना है उनको. आप कर दीजिए अगर
तब नहीं, पहले डॉक्टर अशोक सर को आज के हमारे चीफ गेस्ट हैं.
Right.
And he is a very respected senior member and executive board member from Kerala in CIAP 24. तो आप सर से बात करो और कराओ. And happy learning on this Sunday morning.
Thank you, Dr. Alok. So Dr. Ashok Kumar, as has already been introduced, he is the CIAP EB member from Kerala, is a very senior member, and we have Dr. UMESH Vaidya as a speaker. Dr. UMESH Vaidya is HOD of and Group Director at NICU KEM Hospital Pune and Ankura Hospital Pune. He has been a member of National Neonatology Forum since 1991, and he has held position in NNF in various positions, and he has authored many publications and chapters in books, and his special interest in neonatal nutrition, parental nutrition and human milk banking. That is why he is here. So before I hand over to Dr. Umesh, I request Dr. Ashok Kumar to say a few words on the value of such programs like eNeo course and the value of feeding challenges as a topic for the office-based pediatricians. Over to Dr. Ashok Kumar.
Thank you, Dr. Pankaj. Good morning and greetings from Kerala. The monsoon is heavily pouring in Kerala. But still, I thought Sunday morning it is a good time having a learning program. And in fact, I thank Dr. Alokji for introducing me to this program during the dermatology program. So he also invited for me for one of these programs. And it is a very interesting and a useful learning program for the postgraduates. And the best thing is that you can sit back at your convenience and learn things. That is another interesting point. And as I was already told now, this will reduce the attendee for the other conferences. That is the only disadvantage for this type of program. And I couldn't attend all these programs. I have seen a couple of them, and it is definitely is a useful guide for most of the postgraduates who are. And another interesting thing is that the topics selected are basically useful for pediatricians also. That is the good thing for most. There are many pediatricians who are not practicing neonatology in addition to their regular practice, so they should also be educated and they should be able to handle these babies well. And for the topics today, as you all know, that neonate themselves is a challenge. And when we have a very preterm, extremely preterm, very low birth weight, then the challenges become more and more great. And as a pediatrician, as a professional, we should have a scientific way of approaching it and a practical way of managing it, so that the baby comes out in a wonderful form. And we have Dr. Umesh Vaidya, who need no introduction for the pediatricians all over the country, and is a neonatologist. And he will be talking to us on feeding challenges in the neonate in the next 40-45 minutes. And thank you, Delhi IAP, for inviting me for this program. And over to Dr. Umesh for his presentation. Over to you, sir.
Before I hand over to Dr. Umesh, a word from Dr. Mukesh Dhankad, who is also Secretary of IIT Delhi. And Yeah. Just, Dr. Mukesh, few words from your side.
Sir, so what can I say when I have stars who have been talking about Dr. Umesh Vaidya? So Dr. Umesh Vaidya is a very big thing in terms of feeding newborns in India. We have read a lot of its papers and chapters in the books. Thank you, Dr. Umesh Vaidya, for agreeing to take a talk on this very important topic. And Ashok sir, thank you very much for being a part of this webinar. I know it's on Sunday morning one wants to enjoy the day because it's one of the off days, but still you managed the time out of your precious time for us. Thank you very much, sir. So I think Dr. Pankaj, over to you.
Right. Thank you, Dr. Mukesh and Dr. Alok and Dr. Ashok Kumar, sir. Over to Dr. Umesh Vaidya, sir.
Sure. I'll just share my screen.
Yeah, sure, sir. Sure. Yeah, just do full screen. Yes,
Sure.
fine. Absolutely fine.
Fine. So, very good morning. And before I start, I thank the LAIP, Dr. Pankaj Garg, Dr. Alok Bhandari, Dr. Ashok Kumar, Dr. Mukesh. I think it's a great initiative that you've taken, and I'm very happy to be a part of this. Now, the topic given today is feeding challenges in the neonate. So, when this topic was given to me, I discussed this topic with Dr. Pankaj. And I asked how much time I have, because most of these conferences give you 15 minutes and 20 minutes, and sometimes you have to do things, you have to be very fast. But here I think there is sufficient time and one can be much more relaxed, and one can be much more informal because these topics then can be discussed at length. So what I did is, in this topic, I picked up 7 challenges which I thought we face on a day-to-day basis. And I will be listing those challenges and giving you simple solutions and what is the current best practices for these conditions, especially related to feeding these small babies. So first thing is that why is nutrition important in these small babies? And over a period of time, we knew that nutrition is important. But it's only in the last decade or so that we now realize how important it is. And we only thought that, okay, nutrition makes the babies grow. But we never know that there were so many other outcomes also which are related to nutrition. And as we have been discovering them in the last 10 or 20 years, now we have in fact realized the importance of nutrition even more in the first few days of life. And I'm very sure that all of you have been repeatedly hearing this word, the first 1,000 days of life, first 1,000 days of life. And this has come in the last 10 years, where whichever sort of session you go, people talk of first 1,000 days, first 1,000 days. So this first 1,000 days is from the point of conception to the first 2 years. And what is special about this 1,000 days is that this is a period of maximal developmental plasticity, and it has a greatest potential to affect long-term health. We are talking here of long-term. Whatever happens to that individual in this period can affect 3 generations, and the word is epigenetics. So whatever good or bad you do is going to affect the future. And the word we commonly hear these days is the brain-gut axis. So the brain, the gut, and the microbiome are in constant communication. And by altering the microbiome, a lot of changes can occur in various domains of life. We're just not talking of growth. And of course, as I told you, that you can do a lot of good or a lot of bad in these days. But whatever you do, whichever way you shape these organ systems, you are going to have an impact on the entire life. So these 1,000 days are very vital. And whatever I'm going to mention today are most of these interventions in early life, which are going to have a long-term impact. And I'm going to show some very interesting things to you about how small things that we do can make a big, major impact in the child's life. So we thought nutrition and growth, nutrition and growth, nutrition and growth, but now we say nutrition and the brain. And the brain, 80% of the brain growth occurs in the first 2 years. The new connections being formed. The brain is metabolically very active and consuming most of your energy. And a lot of changes that occur in the brain are very nutrition sensitive. And there are some nutrients which have certain impact on certain parts of the brain. For example, the zinc and the cerebellum, iron and the hippocampus. So these nutrients are so vital. So any deficiency that occurs in early life can have a later impact. And that is the reason why nutrition has to be good and nutrition has to be complete, not with respect to calories and proteins alone, but also with respect to individual nutrients. So this is what we said. Okay, if there is a poor nutrition, maybe less growth, but growth can always catch up. But remember, the neurocognitive impairment that can occur may not catch up. So nowadays we talk of nutrition and neurocognition, and that is the reason why nutrition has assumed tremendous importance in the last 10 or 20 years. So let us now move on to the different challenges that we face. And the first challenge looks very simple: establishing exclusive breastfeeding in full-term infants. You might wonder, what's the great thing? All of us do it. But believe me, the recommendation that the WHO has given, exclusive breastfeeding for first 6 months and introduction of complementary food at the age of 6 months, and breastfeeding to continue 2 years and beyond. If you actually see in our day-to-day practice, all of us struggle to achieve these goals. And if you see the NHS data, it actually shows that these exclusive breastfeeding rates are less than 50%. So something goes wrong, and whatever goes wrong here always goes wrong in the hospital itself. So when I sometimes ask mothers that why are you giving so much of formula, the immediate answer is, sir, it was started in the hospital only. So once the mother is exposed to top feeding in the hospital itself, most mothers will continue to do it at home as well. So we always see this, that we recommend early initiation of breastfeeding soon after birth. They say within the first hour of life or soon after birth. The initial breastfeeding is to be done every 2 to 3 hours. If sometimes you have to wake the baby up, but you have to see that the baby suckled on the breast every 2 to 3 hours. The common argument is, but there's hardly any milk, only few drops are there. So the mother has to be told that his early suckling is meant for you to kickstart the lactation. It may not be for feeding. And that little colostrum which the baby has is usually enough to sustain, especially the baby is term and healthy. We are very careful in our hospitals that we don't give any pre-lacteal feeds or formula unless there is a strong indication to do that. And any kind of formula given to a term healthy baby in our hospital requires the consultant's permission and discussion with the consultant. So we don't do it very casually. And we have strong lactation management systems, which is given to each and every mother. So it's not troubleshooting that if you have a problem, you call a lactation consultant. It is a part and parcel of the service that you provide. And a common thing that mothers say that I'm not feeding, I had a cesarean, that's why I'm giving formula. So they have to be told that cesarean section has nothing to do with breastfeeding, that even immediately post Caesar, the mother can continue to suckle the baby on the breast. And you can see here a lactation consultant in the operation theater suckling the baby immediately on the mother's breast while she's in the recovery room on the trolley. So if you have a system whereby early suckling can be done soon as possible, whether it's a cesarean section or vaginal delivery, I think lactation is established very well. And 95% of our mothers in the hospital, whose babies are term and healthy, are not given any kind of infant formula, whether it's cesarean section or normal delivery. The other important point that I meant to mention here, it all depends on how well you counsel these mothers. If you had a chance to do antenatal counseling, then these things really works wonders. The mother is mentally prepared to do this. So if you get a chance, please in the antenatal period only mention to the mother that we will not be giving formula and we will be suckling a baby soon after birth. You can ask for it. You can tell the hospital system that I want to suckle my baby in the recovery room. Do not separate the mother and the baby and start early suckling, and you will actually do wonders. And this is something that we practice in our day-to-day life. Okay, so this was about term babies, and just be very breast friendly and see that formula feeding is avoided. Now let's look at preterm babies, where I think challenge can be a little more. And the general feeding guidelines that we nowadays follow is, if you have a bigger preterm more than 34 weeks, we will try breast or oral feeding directly, even if the baby may be shifted to the NICU for monitoring, but we will be checking the sugars and try to establish oral or even breastfeeding. Between 32 to 34 weeks, that's a moderate preterm, These are the babies we may start OGT feeds directly. We may start IV fluids if the baby is unwell, has distress or hypoglycemia or is sick. And again, as soon as possible, the baby is stable, we'll switch this baby onto oral feeding, either by spoon or palatine. The smaller preterms, 28 to 32 weeks, or the youngs which are the babies below 28 weeks, these babies will start on IV fluids. We start them on TPN as well if they're below 1500 grams. But we are also strong on enteral nutrition. We'll start minimal enteral feeding. We will start OGT feeds and grade up at a reasonable rate. And at 33, 34 weeks, we transition them onto oral feeding. Of course, the small babies below 28 weeks will directly go onto TPN. But I must mention here to all that no matter what you do for these preterm babies, whatever feeding strategy you follow, be very careful that you monitor the blood glucose. These late preterms, particularly babies 34 to 36 weeks, you have to be particularly careful because these babies look well, but they may underfeed and their blood glucose levels may drop. I've seen a lot of such incidents where people have sort of insisted on oral feeding. The baby is taking some feeds, but the blood sugar level has dropped. Sometimes it has not been monitored. So late preterms, definitely go for oral feeding, but see that at least first 48 to 72 hours, you check the sugars and maintain the blood glucose level, which is above 50, because this has tremendous medico-legal potential. And sometimes in smaller hospitals, we see that blood glucose monitoring may not be done. So kindly be careful about blood glucose. Now, babies who are preterm are shifted to the NICU, and usually the mother is in the postnatal ward or she may be in another hospital. So when we call the obstetrician and say that we want mother's milk, the response of the obstetrician is usually that, oh, I've just delivered a little while ago. How will she get milk? You give formula to the baby because the mother will have a few drops only. What are we going to do with that? So I just wanted to insist on this early expression of milk. How early should it be done? As soon as possible, 1 to 2 hours, first 6 hours? What should exactly be done? And the answer to that would be that even if it is a small preterm baby, you may have a 1 kg baby, you're shifted to the NICU, mother may be in some other hospital. Early expression of milk is very, very important. And I'll show you a very simple study. We are not going to go into the details of that. This is from UK, 4 neonatal units. 132 mothers of single or twin infants. And the outcome they studied was how much milk does the mother have on day 4, 14, and 21 after birth. Very, very interesting. I just don't want you to get confused with this slide. Just look at these blue colored blocks, these blue blocks here, blue rectangles. These are the mothers in whom the milk expression was started within 2 hours of birth. And you can see at day 4, 14, and 21, in all the 3 groups, you can see that this is the group that's the highest. These mothers had the highest amount of milk on day 4, 14, and 21. So the message is these mothers of small preterm babies have been shifted. Immediately within first 2 hours of life, you tell the mother to express milk with a pump. Within 6 hours, so usually as soon as it is possible, it will help lactation to sustain. And there is enough now data to show that mothers who expressed early, they are going to do well. Put your lactation consultant on the job, talk to the obstetrician, and you will get that little bit of milk which the mother has. It will not only benefit the mother, but it's also going to benefit the child. But this is something that we have recently started doing. Baby may be very small. You can see this baby is on a ventilator. But we have taken that little bit of colostrum, either in a syringe or we have taken in a swab. And we swab the baby's oral cavity, though the baby is on a ventilator. And by doing this, you are going to prevent colonization of pathogenic bacteria. And this is going to help feeding. So there is data to show that this oropharyngeal colostrum, it's also called as swabbing. And you can see here that there is less sepsis, increased immunoprotective factors, and it inhibits the pro-inflammatory factors. So very simple thing to do. All of us can do it. Get that little bit of colostrum, put it in the baby's oral cavity. Though the baby may be critically ill, it is going to benefit. We now have a full Cochrane review on this. And it does show that in this very small baby, you can see the weight is 410, 25 weekers and above. Get that little bit of oropharyngeal colostrum, swab the oral cavity. The baby will reach full feeds earlier. And of course, right now we have only 335 infants. but there is some data to show that it benefits. Very simple intervention, no cost involved. It's just a change of attitude. So from this talk, if you're going to take one message today, take this message of oropharyngeal colostrum. It's going to help a lot of babies in the NICU. Let us go to challenge number 3, how to establish and maintain the milk supply in mothers of preterm babies. Another thing that I commonly see, you say a preterm baby, you ask the mother, why are you not feeding? Mera bachcha NICU mein tha na. So being in the NICU cannot be a reason not to supply mother's milk for a year. In fact, it's the preterm babies in whom this mothers will be more crucial than a term baby. So what do we do? First thing I already told you, that early expression of milk. We have very tight control on the use of infant formula, even in the NICU. We have dedicated lactation consultants, 2 of them. One looks after the postnatal wards and one looks after the NICU. Round the clock, from 9 to 5, the lactation consultant will be with the mothers. It makes a tremendous difference. We have a human milk bank, but if you don't have one, you can always liaison with a bank close by, because human milk bank allows a lot of human milk supply and less use of formula. One has to motivate mothers and help them to come into the unit and be with the baby. I've seen mothers stay at home and they would visit once in a day. It really doesn't help. So tell the mothers to visit more often, involve her in the care of the baby. And if you give her kangaroo care and NNS, things are going to benefit. You may need some galactogogues, a good dietary habits for the mother. And the entire NICU, your nurses, your registrars, the consultants, everybody has to be very, very pro breastfeeding. And this is what we practice. And we are very happy that in our NICU, I would say majority of the babies, more than 95%, would be receiving only human milk, mother's own milk, or maybe pasteurized donor human milk. Very few of them, suppose there are very few who don't give consent to donor milk, where sometimes we may have to use a little bit of formula. But by and large, our NICU is very, very pro breast friendly. Again, as I mentioned to you that the early expression of milk is done soon after birth. Similarly, if the mother is pumping milk more than 6 times a day, her milk output is going to be more. So you must allow mothers to pump at home as well. They may need a better pump. They may have to be trained in using a pump. And the more often that they express milk by a pump, the more they are going to benefit and sustain lactation. Another study to show that mothers who did pump more often, more than 6 times in a day, they could supply much more milk to their small babies. So again, in preterm babies, take it as a challenge and see to it that these mothers provide their own milk. Now, this is the reason that I was mentioning. Just see this interesting slide. You can see the duration of breastfeeding shown in this block here. 4 to 7 weeks, 8 to 11, 12 to 19. And you can see the IQ points which actually go up. The longer you feed, additional IQ points you get. If you're a low birth weight, you're going to get 5 points plus. And if you're normal weight, you're going to get around 3 points plus in your IQ. And the studies by Alan Lucas actually have shown that these benefits in the IQ that you get because of breastfeeding sustain well up to 22 years. So when most of your education, your NEET and your JE and all these exams, if your IQ benefits are going to sustain till 20, 25 years, you can imagine a definite and academic, better academic future for this very small baby. Again, another study to show that the longer you feed, you can see here 1 month, 2 to 3 months, 4 to that, you can see a very dose-dependent increase in IQ when the mothers breastfeed for a longer time. And what I find is when I tell this to moms, moms tend to breastfeed with very good diligence and dedication. You tell them about less allergy, less infection, somehow it doesn't impress them a lot because I boil my bottles well, I am very hygienic and all that stuff. They have a sterilizer at home. But when you tell them that your baby is going to get a better IQ, then these mothers are much more motivated to feed. So use this for your counseling and allow mothers to feed more. If you're low birth weight, you're actually going to benefit much better if you breastfeed. The fourth challenge coming to that there's a feed intolerance. So these babies are kept in the NICU, these babies are kept on orogastric feeds, and these babies somehow they don't do well and they have a lot of feed intolerance. And we're all very scared. We have small babies. We're all worried about NEC. And that is the reason why even the doctors or consultants would feed babies very, very slowly. And sorry, the slides are stuck. Yeah. So because there is risk factor, the obstetrician has told you that there was abnormal Doppler, this is a growth restricted baby, mother had PIH. So the doctors are very scared because the risk factors, I don't want to be caught with NEC, let me feed this baby very slowly. And all of you know this gentleman, this is Sachin Tendulkar, and you can see that he's not looking at the ball, he's gone onto the back foot and playing this ball with his head down. So this is what happens when there are risk factors. IUGR baby, people are so scared of NEC that they will be withholding feeds at the slightest problem, mild distension. They immediately stop feeding. They grade up very slowly. I've seen people grade up 0.5 ml a day, very tiny amounts. And something happens, mild aspirate, they start antibiotics. So this morbid fear of NEC leads to a lot of growth faltering and antibiotic abuse. And this is an individual characteristic of every consultant. So some consultants are a little brave, some consultants are very scared, and they grade up babies very small, leading to a lot of EUGR and a lot of problems in these small babies. But again, we say, what are signs of feed intolerance? The minute somebody gets an aspirate, somebody says no, gastric aspirates means feed intolerance, I'm not going to feed. Somebody says green colored aspirates, oh my God, because you can see on the right is a very light green. Somebody says lemon yellow aspirates, I'm worried about. Somebody says, I check abdominal girth, I don't check aspirates. And somebody says visible bowel loops, I will take a side of feed intolerance. Some people say, well, I don't know what is right. Maybe any of them, none of them, I don't know. But what are the certain signs that we should know? Because if we don't know the right things, then we may end up feeding babies very, very slowly. So now there's been a lot of IPL, there's been a lot of World Cup that we saw recently. So the umpires will then refer to a third umpire that what exactly is right? How do you give this decision? And please tell us when the batsman is clearly out. When I say, yes, this is feeding intolerance. So the only factors which suggest that definite signs of feed intolerance, if you are vomiting, if you have large hemorrhagic aspirates and tense abdominal distension, these are definite signs. In fact, all the above, if you see lemon, yellow, green aspirates, more than 50%, visible loops, abdominal girth, all of them, if you put them to the test of evidence, they really don't stand out. There are not much studies to suggest that these things really suggest feed intolerance. So what we in our unit would do is we look at the child, look at the abdomen, look at the aspirates, and we look at everything together and make a judgment. For the sake of studies, which you do on nutrition, some definition has to be there. And the definition what we currently is most accepted is the aspirates more than 50%, abdominal distension or vomiting or both, leading to disruption of feeding plan. Now, this is something that most people would accept. But if you have seen here that it is a combination, it is still gastric aspirates, abdominal distension, vomiting. So we're looking at everything together. We're looking at the clinical condition of the baby and then taking a call whether we should really call it feed intolerance. Well, you may call it, but do you really need to change the feeding plan? So what is to be practiced? So these gastric aspirates, you don't have to do them regularly if the baby is a very stable baby with not much risk factor. I have a 32-weeker, 1600 gram, no risk factors whatsoever in the mother. This I may not even check the gastric aspirates. I might just look at the abdomen and feed this baby. In high-risk babies like the ones I mentioned, initially don't check the gastric aspirate, first 3 to 5 ml, because whatever you give, you're going to get it back. Once you cross 3 to 5 ml per feed, then you may aspirate. If you get an aspirate which is greater than 50% of the feed volume, give it back and hold the next feed. If the aspirates are still persistent and increasing, then you may have to decrease or stop feeding. So don't be in a great hurry to stop feeding immediately if you get a little aspirate. Just look at the baby, look at what's the color of the aspirate, and then take a call. Again, use a small syringe, and it's always a good idea to keep the baby prone for 30 minutes post-feed. This is known to improve feed tolerance. Very interesting study about preterms. One group, there are routine aspiration and the feeds are directed by aspiration. The other group, no gastric aspiration. And you can see there is hardly any difference. In fact, the babies who did not aspirate reach feeds earlier. So in our NICUs, again, Babies who are stable babies, bigger babies, no risk factors, we would not aspirate them. Babies who are small, great risk factors, we would aspirate them a little later, 3 to 5 ml of feed. We would look at the abdomen, bowel sound, stooling pattern, clinical condition of the baby, and then take a call. But we are generally very, very pro feeding. We would take, it would need some strong reason for us to slow down the feeds. Regarding grading up, again, there's a fear of NEC. People say, no, no, this baby is small. I'm going to feed very slowly. Again, data doesn't support that. You can grade up even the small babies you can see below 1500 grams, below 32 weeks, 35 ml per kg per day. So baby will be on full feeds by day 5. And there is a recent study also, the SIFT trial, that also shows that even in these babies below 1500 grams, even if you increase at 30 ml per kilo, you're not going to get more NEC. And in fact, the neurodevelopment also and the survival will be the same as slow grading up. So data does not support slow grading up. 30 ml per kg is safe. Okay, if you are scared, go at 20 ml per kg, but please don't go below 20 ml per kg unless there are strong and confirmed signs of feed intolerance, which I showed you. So we are a little bold and brave. Most of our small babies would be on full feeds by day 7, maybe latest day 9 if there is some problem. But we are very strong on feeding these babies enterally and using mother's own milk. Very good paper, very interesting study from our president, Dr. Sushma Nangia, where these babies 1 to 1.5 kg who have been stable, no IV fluids, they're directly put on full enteral feeds at say 80 ml per kg. They have a human milk bank. They have sufficient supply of human milk, and these babies do extremely well. Remember, less earlier full feeds, less hospital stay, no increase in NEC, again, less intervention, saving staff time, saving nursing time. And this is something that is very relevant to our country, and we should be practicing this. We do it in stable, bigger babies. Most of the times it does succeed. But again, remember, you need to have human milk, always better to be associated with a human milk bank. But a very impressive study and something that is very relevant to us. So what we do, well, we take sort of cognizance of those risk factors, but just the fear of NEC doesn't slow us down. We do not give too much importance to gastric aspirates. We have a very positive approach to enteral feeding. We don't use domperidone or metoclopramide very regularly. Probiotics, there is some evidence to show that it improves feed tolerance. Oropharyngeal colostrum, some evidence to show. Kangaroo mother care, definite evidence to show that there is a better feed tolerance. And in certain babies who are getting intermittent distension, suppositories and enemas are known to help feed intolerance. So some babies it may help. There is a very small studies to show that if you have getting recurrent distension, you may use a suppository or an enema. But I think the most important part is your approach and attitude, which has to be very positive and promotive. Going to the 5th challenge, we have total 7 challenges. We are talking of the 5th now, how to sustain growth in NICU. So the AP goal that even the baby is born, prevent growth failure. So I think that's your primary aim. Do not allow extrauterine growth restriction. Achieve optimal growth, and if possible, if you're really sort of very good in your work, you may even be able to achieve in utero growth rates, which is ideal. And there are some of our babies who actually attain that. Just see on the left of the slide. So the smaller you are, this is the smallest group, 500 to 700 grams. The smallest babies require higher protein, up to 4 grams per kg. These are babies below 1200 grams. And as you go to bigger weight category, birth weight, your protein requirement goes down a little. But if you overall see the requirement between 3.4 to 4, 3.4 to 4. On the other hand, if you look at the energy requirement, the smaller you are, you're going to require a little lesser energy. But in the bigger babies, they need a little more energy. But you are 110 to 135. So this is what you should be aware, that the smaller you are, you're going to need more proteins. And that is why you must see that your protein intake is adequate. And what is intrauterine growth rate? You can see here that this baby has lost a little weight and then going parallel. And 16 grams per kg per day is the rate that we want the baby to grow at. And this then will be parallel to the intrauterine growth curves. For a very long time, we believed that this is not possible. And we say, no, once the baby is born, it's impossible. The womb is different, the environment is different. Once the baby is born, there is morbidity, the thermoregulation suffers, and babies don't tolerate feeds. We cannot give full TPN, so babies cannot grow at this rate. Well, we also thought so once upon a time. Now our babies do grow at this rate, sometimes even better than this rate, if you do the right things. And I'll show you how that is actually done. So we do achieve intrauterine growth rate. At the same time, we do not increase NEC, and we also prevent metabolic syndrome. So this is what you want. Good growth without problems in the short term or the long term. And we are able to succeed in most of these outcomes in our units. So what we say, okay, in utero growth is our final aim, at least 10 to 15 gram per kg per day, and also look at the length and the weight gain in these small babies. So what do? We see to it that we are giving adequate calories and proteins. Like you had a PEM case in the past, we used to see this in the wards during our training. So the consultants told us caloric and protein intake we calculated, and we made a diet plan. So same thing we do here. So we see whether the baby is receiving adequate protein and calories or not, especially the proteins. Early parental nutrition is started in the small babies. We give individualized nutrition, which I'm going to talk about. We are not afraid of NEC. We are careful, but we are not put down by NEC, the fear of NEC. And we know how to understand, how to recognize feed intolerance, and we feed positively in spite of this. So some of these things I've already touched upon, but essentially to maintain this calorie protein intake, we need to fortify breast milk. See only the last column, that if you use breast milk given at 200 ml per kilo, you can see here that there are deficits which are there in proteins, in calcium, in phosphorus, in zinc, in vitamins, vitamin D also you can see the deficit. So if you give even breast mother's own milk even 200 ml per kg, in the small preterm you are going to get deficits, and where comes the concept of human milk fortifiers. So when you add these human milk fortifiers to mother's milk, you are going to give increased protein, calcium, phosphorus, iron, and vitamin D. Most babies below 1500 grams will be receiving human milk fortifiers at least till they reach 2 kilos or they are established on breastfeeding. So human milk fortifiers have a role to play. I've just shown you here that when you use the standard bovine fortifier, you can see here that you have got enough calcium, enough phosphorus, your calories 144, protein has gone to 4, and you have enough vitamin D and iron. So fortification actually will help the baby to get adequate calories and proteins. And we also have a human milk-based fortifier now, and that also can be used, but of course has less vitamin D and iron, so you may have to supplement this extra. So people have to use a fortifier in these small babies. When I mentioned the word individualized fortification or individualized nutrition, we had made a software many years ago. This was somewhere in the 90s. So this software can be easily used at the bedside, and it helps us to calculate the enteral and parental caloric intake. So this is the screenshot of that, and we can see here the scroll bars on which we can calculate the amino acid, the proteins, the lipids, the fluids. We also have an interface for enteral nutrition. So how much milk we are using, are you fortifying it? And this software gives you a correct idea as to how much calories you are giving, how much proteins you are giving, and whether it is adequate or not. And it also gives you the difference in the enteral and parental. And most important, also plots a growth chart for you. So you get a good idea as to what you are actually giving the baby, and you also see how the baby is growing. So you can actually scale up your calories and proteins so that you are doing the maximum. So when you drive a car, you have an accelerator, you have a speedometer in front of you. So if you know that the speed of your car is slow and you want to accelerate, you want to overtake someone, you'll press the accelerator and get the necessary speed on the speedometer. So this software exactly tells you what you are giving and what you are getting. And that is how it helps you to individualize the nutrition. If the baby is growing slowly, we would increase the calories and proteins. If the baby is growing well, we may not do that. So this has helped us to get very reasonable growth. We use it for each and every baby at the bedside. And this helps us to drive their nutrition well. And you can see this growth curve. You can see this small baby. We grade up fast. We give good proteins. We plot the growth chart. And remember, this growth chart, which you can see, has been done by the software. and we tailor-made individualized nutrition supplementation. We also look at the ferritin levels, look at the calcium phosphate, alkaline phosphatase. So even the nutrients that we give these babies, we check them and we optimize them. So you have optimize calories, optimize protein, optimize fluid intake, give the right iron, right calcium, right phosphorus. Believe me, you can see this baby on the right. You can see the baby grow parallel to the intrauterine growth curve. You can see the increasing length as well as head circumference. And this is something that really makes them grow well and changes outcomes. So this is what we have been practicing for the last 8 or 10 years. And right now we are driving growth reasonably well in our babies. Non-nutritious sucking helps. This is a nutritionist supportive intervention. So when the mother is available, baby may be tube fed, allow the baby to suckle a little bit on the breast, and that's going to help establishment of early feeding. And of course, kangaroo mother care, something that people talk a lot. But when I actually see many units, I don't see this being done so often. So we discuss a lot about this. Small, stable babies in the NICU encourage the whole family to give kangaroo mother care. So we call in grandmothers, we call in the older siblings sometimes, we call in the father, we tell him to talk to other fathers, and we try to give a lot of kangaroo mother care, even in the NICU, and we tell them to do it at home as well. Just look at this one sentence here. If kangaroo mother care alone reduces mortality by 32%, infection by 15%, hypothermia by 68%. Again, such a simple intervention to do. We just have to see that we change our attitude and practice. We motivate mothers and work with the family to do it. And it itself is going to change your outcomes. Now, the sixth challenge, and I think this concerns the pediatricians, is what happens after discharge. So sometimes there is a small baby who's come out of the NICU, and now this baby comes to the busy pediatric clinic, and it gets diluted with the other well children or the sick children, and the nutrition may suffer after discharge. So this is a real case. This is a small baby went home, 710 grams, went home at 33 weeks at 1.3 kg, and sometimes you don't discharge normally at 1.3 kg. But parents insist their financial issues and they say, no, we can't stay anymore, and they take early discharge. This, in spite of telling that they did not come back early, they came back after a month. After a month, this baby hasn't grown at all. In fact, has lost 100 grams. So this is something that commonly happens in our practice. And we must see why this happens and what can be done to see that even after discharge, these babies continue to grow at a slightly better rate. So what could be the reasons for poor growth? Let us just look at it. Commonest is inadequate feeding. The mother is trying to feed this baby. The baby is a little sleepy and sluggish, not swallowing properly. The amount of intake that the baby is requiring is very less. The taking is very less. Mother may have less milk because she's not directly suckling. She's expressing the milk. There is cold stress. In the baby was in NICU, but was an incubator warmer. Now the baby is exposed to cold stress. The anemia may get exaggerated. Usually we know that these babies can become anemic at 4 to 8 weeks, and some of the hemoglobins drop to 5 and 6. Babies don't grow. You stop the fortifier when sending the baby home, calorie proteins drop. The baby may have an occult infection. Sometimes babies develop UTI or then sepsis. They also develop a late onset hyponatremia. So if you have a small baby not growing, always check the electrolytes. Sodium is usually an issue. Zinc deficiency has been known to be a cause of small poor growth, and these babies also have GER. So all these factors need to be considered when a baby comes to you for follow-up and is not growing. Things that are commonly not realized are cold stress, the anemia of prematurity, and the electrolyte deficiency and the sodium deficiency. That is something that sometimes is not picked up very easily, and those things must be looked into. So we ask the mother, how is the baby feeding? And the answer will come, oh, the baby is very sleepy. Feeding takes more than an hour. He doesn't take only, you have to keep on waking him up. That actually tells you that this baby is not doing well. And usually these babies take a very long time. The mother says, I take more than an hour to feed, and the baby is very sleepy, then you have a problem. Many times they do not fortify at home. You ask for the urine frequency, ask for signs of sickness, ask whether the mother is giving oil massage and the medications, whether she's actually giving them regularly or not. I think this is very, very important. So we assess the milk intake. A 1.6 kg baby that has gone home, this baby is expected to take at least 240 ml if you want to grow. So ask the mother how many feeds you give, what is the feed volume that you are giving. And sometimes you realize that the baby needed 240, and the mother's total that we see comes to like 160 or 165. So we know that baby may be taking 8 to 10 feeds, but the feed volume is very less. The baby is very sleepy. So assess the feed volume. Most babies are on Vati spoon feed, so it's easy to calculate. Check the mother's lactation, see if she's using a pump. She may need some support, and some babies may need a little supplemental formula because the mother just may not be able to express the amount of milk that the baby may require. Of course, see that KMC and RNS are continued at home. This transition from spoon feeding to breastfeeding has to be done properly. So sometimes mother on their own baby is 1.7 kg and she stops expressing and starts feeding this baby on the breast. Baby may not be ready, the suck may be ill-sustained, milk transfer may be very less, and then these babies don't grow. So always assess whether the baby is ready for direct breastfeeding, is the baby sufficient, the suck is sustained, whether the baby is growing well or not, how is the latch. Sometimes the baby may be small and the nipple may be very large. So this transition from spoon feeding to breastfeeding must be done correctly and supervised. Maybe tell your nurse to have a look if the baby is really suckling well and for how long. Usually the transition to total breastfeeding usually occurs around 2 kg. Some babies may take a little longer. Some babies, in spite of all the other things, still growing slowly, and you may be able to give human milk fortifier after discharge as well. So express a little milk, mix the sachet, give it by spoon, and then the mother can put the baby on the breast. So remember, HMF can be used after discharge. Please do not use MCT oil. That's something that we see all the time. MCT oil is not recommended, and HMF may be given after discharge for better growth. We think that parents are very clever. Why you have to tell them about wrapping a baby? But we have seen even the most intelligent mothers sometimes do not know how to wrap the baby properly. Hands and feet are very cold. The baby is under cold stress, and that's one of the reasons why these babies don't grow. So teach them how to wrap and clothe. Defer the bath till 2 kg. Advise kangaroo care at home, and also recommend oil massage. And it also is in the WHO guidelines. I think this is an area where I always see that there are issues. What exactly is to be given to these babies at the time of discharge? You have a preterm going home. So when they are at the point of discharge, you start them on a multivitamin preparation contains zinc. Remember, all multivitamin brands in the market do not have zinc. So choose one which has zinc. Give a calcium preparation that has phosphorus in it. We need phosphorus as well. So if you use calcium lactobionate or some other preparation, you're missing out on the phosphorus which the small preterm babies require. And of course, vitamin D is also needed. So these are the three supplements that are prescribed at the time of discharge. Make a standard discharge prescription for your NICU. Iron supplementation commonly forgotten. I get many preterm low birth weights in my clinic where I see that the child may be on a multivitamin preparation and a calcium, but has certainly missed out on iron, and iron is recommended 2 to 4 weeks. For the sake of simplicity, I always tell people for a preterm baby, start iron at 4 weeks, for a term baby, 4 months. Even a term baby who is breastfed needs iron supplementation as per international guidelines as well as by IEP guidelines. So don't forget iron and use multivitamin with zinc, calcium, phosphorus preparation, vitamin D. Don't forget to start iron at 4 weeks. Now, as I mentioned earlier, there are some babies who go home on HMF. Now, HMF contains vitamins, HMF contains zinc, HMF contains calcium, phosphorus, HMF contains vitamin D, HMF contains iron. So if your baby is receiving HMF at the time of discharge and you recommended that for a few weeks, during the time that the baby is receiving the HMF, do not give any supplements because they are also present in HMF. Once you stop your HMF, then you can start this supplement. So be very careful, otherwise there will be overdosing. Don't go into these values, but remember that the vitamin A is around 1500 units. See the dose of calcium phosphorus. It is around, I remember it as 200 and 100. It's easy to remember. And vitamin D, 400 to 800 by WHO and 400 to 700 IU per kg by SPGAM. So what we generally remember is we accept around 800 international units for our small babies. And the iron supplementation is 2 to 3 milligram per kilogram per day. So I've seen doctors just advise 2 drops BD, 3 drops BD. So don't write that. Actually calculate what is the correct iron requirement for that baby. And the baby may have different iron needs. So what has come in the current recommendations, that whenever you discharge these babies on iron, if you're taking a blood sample, check the serum ferritin. And if the serum ferritin is low, you may have to increase the iron dose. While low, you can see less than 40. You may have to increase the iron dose. If the ferritin is high, usually happens in babies who have received transfusions in the NICU, then you may hold back the iron for some time till your ferritin level drops below 100. And this is something that you started doing. And we would recommend that in the small preterms that go home, just don't go on the hemoglobin. You may have to check the serum ferritin levels in these small babies. How long to give the supplements? Vitamin D and iron, there is no question that these have to be given for 1 year. So iron, vitamin D, straight away to be given for 1 year. The confusion is about multivitamins and calcium phosphorus. So I tried to look into a lot of literature to see what is the correct thing for multivitamin and calcium. I also discussed with many people. Unfortunately, there is no guideline. Even if you see WHO or any other guideline, SPGAN, AAP, they do not say how long to give the vitamins and calcium phosphorus. But one sentence which I repeatedly found was they say that these supplements should be continued till appropriate complementary feeding is sufficient to meet the daily requirements. So we draw an inference that breast milk has less vitamin A, zinc, and calcium phosphorus. So obviously, if you're going to wait for good complementary feeding to be established, then certainly you may have to wait for 6 to 12 months. So this is what the inference which I drew, that vitamin D, iron 1 year, and multivitamin and calcium phosphorus at least for 6 months. But if you want, you can continue that till 1 year as well. Now, this was a module that I made for the Indian Academy of Pediatrics, and it was rolled out last year. And in the peer review, everyone agreed that yes, what you have written is reasonable, because we may have to continue it for a longer time. So make a policy of supplements for units, choose your brands properly, and tell everyone to follow this very, very diligently. I'm showing this slide. I have not deliberately written the names of these brands, but you can just see that the calcium phosphorus varies. So brand A is 82 and 41, brand B 150 and 75. So the doses are different. So choose the brand for your NICU, which and calculate dose correctly. So everyone in your unit will use the same brand. Same thing happens to iron. This one brand has 25 milligrams per ml, other brand has only 10. So then you need to decide that if I'm going to use brand A, what will be the dose? If I use brand B, what will be the dose? So right, choose your brands and make a proper policy. Multivitamins also, you can see brand A 3000 international units of vitamin A, brand B has 1000. So write the dose in ml. Don't write 5 drops OD, 5 drops PD. Write in ml based on vitamin A. So brand A, it is 0.5 ml. If you're giving brand B, it is 1 ml. So make someone sit, do it. If you want me to send it to you, I can send it to Dr. Pankaj. You can send it to all of you, the brands that we use. But in a scientific presentation, I usually sort of tend to not use any brands and promote any brands. But if you want it on a personal basis, I can send it to Dr. Pankaj and you can start implementing this in your unit. So choose your brands correctly, check the doses correctly, look at the market preparations, and be careful that vitamin D may be present in the multivitamin also, it is present in the calcium preparation also, and you may be giving it separately as well. So sometimes it can lead to overdosing also. So you need to balance it out to see. But if you want a ready-made formula that we give, we will be sending it to you, and then you don't have to worry too much. Coming to the last challenge now, and this challenge is about preventing metabolic syndrome in later life. It is tremendously relevant to India, tremendously relevant, because we have growth restricted babies and we are prone to develop diabetes and hypertension and ischemic heart. We are aggressively feeding our babies. Our parents want babies to grow well. So what happens is these exposures that you see on top in the blue. So whatever we do regarding nutrition, prenatally and postnatally, is going to affect these 5 agents here: hormones, metabolome, microbiome, epigenome, and growth. And these are going to finally lead to adult problems which are shown down: obesity, insulin resistance, diabetes, ischemic heart disease. So we have to control these exposures on the top so that we do not land up in big trouble. We have seen on the left that overnutrition in the fetal postnatal area, and both fetal and postnatal. Look at the right. So many problems: obesity, adiposity, insulin resistance, diabetes, ischemic heart. We have to be careful. We don't push the baby into that, and we have some reason to believe that our small babies are landing up in trouble later. Maybe they land up with the adult physician. The adult physician does not know the early risk factors, and these babies, we have actually done more harm to them because we have pushed them into a metabolic syndrome, which is going to cause limitations in their life. So what do? In the first year of life, don't bother much about anything else. Think only of the brain. You give them good nutrition, give them good iron, give them good stimulation, good proteins, good micronutrients, good iron, good zinc. See that you focus on the brain, make them grow well, because let the brain develop well in the first year of life. But as the small baby is growing up into early school going age, and as an adolescent, be very careful that you are restricting the high calorie foods. Plot the growth chart, see that we are not getting obese, prevent micronutrient deficiency, put the child in a very good physical activity program. In fact, I tell people that the child has to be on the playground or the park. नहीं घर में बहुत दंगा मस्ती करता है. That has no meaning whatsoever. Put the child into good physical activity and prevent obesity. So our problem doesn't end with a preterm baby till the child becomes an adolescent. We have to prevent obesity later on. So I conclude now. The thing that I showed you today is mainly early nutrition is important, and it affects your growth, neurocognition, as well as metabolic health in later life. And we've seen all these different mechanisms, how the IQ can change, how your diabetes can occur. So all these things are so important, and we have to do the right things in early infancy. I showed you a total of 7 challenges. And those 7 challenges were that in the breastfeeding has to be established in term healthy babies, lot to do in the hospitals, lot of motivation required. If you're preterm, even more important. Early expression, very important. Involve the mother. See that you don't use milk substitutes. Use human milk as much as possible. See that this milk lactation sustains for more than a year. Interpret feed intolerance correctly. Do not be scared of NEC and slow down your feeding. Be positive. Post-discharge growth and supplements, very vital. See that you plot the growth chart. See that you're giving the right supplements. Prevent iron deficiency. Prevent vitamin D deficiency. And every small baby that you see, please see that you're looking at the long-term health of that baby. Just don't think short-term. See that these babies come to you for follow-up at least once in a year and repeatedly educate them about the metabolic syndrome. Thank you very much.
Thank you, Dr. Umesh. I think your presentation, as always, is very crisp and get very pertinent points to all of us. So first to Dr. Ashok Kumar, your comment, sir.
Yeah, thank you, Dr. Umesh. And you have comprehensively presented the problem, nutritional challenges in a very short period of time. A few points I also would like to see very important as far as here in your presentation. Lactation counseling, that is a very important point. In antenatal lactation counseling is very, very important, and our gynae colleagues should help us in a big way. So that is a very, very important thing. And another thing is relating breastfeeding in intelligence. That is a very good point. When that is a point when we can tell the parents, and it will have a very good impress. And blood glucose monitoring. This is one point every pediatrician, every who taking care of newborns should follow. That is a very, very important point you have brought up. And a new thing came to I have never attended so many neonatology oropharyngeal swabbing of colostrum. Is it a new thing, or is this happening for some time?
Yes, it's relatively new, but I would say when I say new, it's 5 years.
Yeah,
so
yes. This is one practically useful point when you can in what I feel is that you say this is an express colostrum you can swab. The mother will be also interested to express the colostrum.
Exactly.
That is another point. Yeah. And another concept you have said is that using a human milk fortifier, you can achieve intrauterine growth rate. That is again a very important point we have to emphasize both in the medical professionals as well as the parents, so that the feeding pattern and the feeding thing can be done well. And in fact, the post-discharge feeding also very important. I think you have covered entirely the entire gamuts of feeding challenges. And I have a few questions in the chat box. What will do when gynecologists say that start breastfeeding when we will sit mother in 24 hours up? This is one point whether the mother cannot sit up and feed, they cannot turn and feed. And this is one point usually practical thing. I think we have to insist on breastfeeding. That should be our attitude.
Gynec, it's a difficult, so that's a bigger challenge for us to change the behavior of the gynecologist, and all of us find difficult people, but somehow we have to convince them to do this.
Again, then question is colostrum swabbing. Can it be done even good sucking has been established?
No, it won't be required.
There is no need of it. And how much HMF recommended on breastfed, and how long it should be given?
So this HMF has a very standard way of preparation. It is one sachet, that's 1 gram in the 25 ml of milk. But as I mentioned, with the baby's breastfeeding, you don't have to express 25 ml. You can express 5 ml, mix the HMF, give it by a spoon, and then put the baby on the breast. So in NICU, you may have a full 25 ml of milk express, but if baby is on the breast, you can just have some milk just to mix the HMF.
Then the dose of iron, I think you have mentioned, depending upon
it is 2 to 3 milligram per kilogram.
Yeah, you have to. And important thing is that you should know which brand, the content in the brand which is using. That is more important.
Correct.
That is very important. Kindly elaborate on HMF supplement and how many times it should be added in a day.
So it is in every feed, but a maximum of 8 HMF sachets per day. You cannot give more than 8, because if you do that, then your vitamin D will cross 1000. Babies usually feed 8 times or 9 times in a day. So 8 sachets can be given in one day.
Okay. There is one question, anonymous attendee, he don't want to identify himself. Any specific reason why MCT oil is not recommended?
MCT oil.
Yeah, so MCT oil is a monocomponent fortification, and the data currently goes against monocomponent fortification. So when you have a good HMF, which contains everything, carbohydrates, proteins, fats, iron, vitamins, and minerals, then when you have a complete product like that, an MCT oil alone, which gives only fat, may not be recommended. So globally, there are hardly any studies on this, and that one study which have also is against MCT oil. And it may push the child into metabolic syndrome because loading only fat in that child.
Dr. Pankaj, there is enough time. A few more questions are there.
Yeah, please go ahead. We have enough time, sir.
Then there is a query on vitamin D dose, whether it is 400 international unit or 800 international unit till 1 year.
Okay, so again, 800 is international units is what SPGAN says, and what AAP says. The IAP still says 400, but when I discussed with them, I was told that the guidelines of IAP are also going to be modified. We might be recommending 800, but remember, maximum dose is 1000.
And there is one query regarding the breast pump, which is better.
So if you are going to
explain
be using,
what is it?
If it is going to be short term, then manual pumps are fine. But if it's going to be a long term expression, babies in the NICU for a month or 2, then I think electric breast pumps. Most large NICUs have hospital grade pumps, which multiple mothers can use.
Another question is, during progression of feeding mode, it is only gestation, or we have to take the weight also in the account?
I think the gestation and weight both have to be taken into account. The risk factors have to be taken into account, and the type of milk has to be taken into account.
That's an interesting question by Dr. G.K. Kapoor. In spite of telling mothers about lactation, they're still reluctant to regarding. I think role of lactation counselor is great in this area.
So I will tell you that I was telling one of my lactation consultant only that to promote and motivate mothers for lactation, you have to be a strength like a spiritual guru. Your counseling power has to be such, the way you explain and the words that you use and the way you appreciate the mothers and encourage, you talk about the IQ. And I find very few mothers who are reluctant and just not ready, but majority of the mothers whom I see, I would say more than 95% would be motivated and do it. But there are some mothers who just are not ready. And previously I used to get very angry and annoyed at them, but nowadays I realize that if she doesn't have the motivation in her, it is going to be difficult for me. It's like a teacher who teaches students. Some of them are going to be very sincere, and 1 or 2 students in the class are just not going to bother. So I think you do your best, finally leave it to their wisdom. But if you have a more than 95% success, I think you're doing a good job.
Yeah. I think now the younger mothers, they have many stresses other than this, and you have to understand that part also when you counsel them. And that not only lactation counseling, a proper counseling is needed along with the lactation counseling. I think there is another question regarding the HMF and how many. I think you have answered that,
Yeah.
right? Maximum 8 to be done. Dose of calcium, phosphorus also you have mentioned.
200 and 100.
Yeah, that you have mentioned. Preterm IUGR neonate successfully established breastfeeding already while was in ICU, but decreased suckling once shifted to the mother side.
Okay, one is the latch could be wrong. So recheck the latch again, check the mother's milk supply again, check her hold, and some babies may need oromotor stimulation, and see that she's not using a pacifier as she's not started a bottle. Because sometimes with the breast pump, there's a bottle that comes along with it. So mothers sometimes without telling us have started using the bottle for expressed milk. So just see that nothing else has come. And I heard a very nice sentence in between by someone that there should be no business between the baby, the breast and the baby. So using shields and pacifiers and bottles and such things should not be introduced.
This another question is regarding HMF to formula milk. Is it?
No,
I think
never.
most of the
It
formula not required.
No, it is human milk fortifier, so it's only for human milk.
I think there is question regarding HMF available. I think it is not proper.
Yeah, no, what I'll do is I'll send that slide also to Dr. Pankaj. He can send it to others. There are around 4 to 5 different brands in the market now. So I will send that slide also to Dr. Pankaj to send it to everyone.
Sure, I will do that.
Then one question is on oil massaging. Should it do after bath or before bath, or what age and weight?
So what usually done is that we start giving oil massage only when these babies are stable. And this oil massage in the NICU also it can be done. It can be done once or twice in a day. You can also allow the mother to do it even in the smallest or small babies. When they go home, we tell them to give the traditional oil massage only after 2 kilos, and preferably by the mother or the family member only. Because sometimes these ladies who come for massage can be very harsh on the small baby. And the massage technique may be taught in the NICU as well, only before going home.
At what day of life should vitamin D be added in a term baby?
It is soon after birth. Soon after birth.
That's on the day 1 you can give vitamin D.
Yeah.
And human milk banks, I don't know what the question they have asked.
Yeah, it's important that if you have an NICU and small babies, you must have a MOU or liaison with a human milk bank closest to you, because everyone need not have a human milk bank. So we also have a model. We have 1 milk bank and we supply milk to 9 milk banks. So you must try to find out which human milk bank is closest to you.
The question is it wise to use calcium with vitamin D as a routine thing?
If you see recommendations for term healthy babies, calcium supplementation is not required. So we see most of these big babies put onto osteocalcium. It's not needed. Term healthy babies, only vitamin D. Preterm babies will need calcium and phosphorus along with vitamin D.
No, I have a problem occasionally. When you check the calcium, if you see calcium low in a term baby itself, is it okay to supplement calcium? Or?
Yes. If you have hypocalcemia, you're an infant or diabetic mother, you may have to give extra calcium.
Okay, fine. Then parents arbitrarily increase EBM via KS feeds, which result in overweight and increase in stool.
Yeah, so what I have recently seen is that a lot of mothers now unnecessarily, they remove their milk and give it from a bottle. So sometimes you must know that a term healthy baby, there is no reason to express milk and give. Term healthy baby should feed directly on the breast. So I don't allow them to express and give it. Secondly, some mothers, for some strange reason or recommendation from the friend, give 1 or 2 extra formula feeds. मैं रात को 1-2 बार देती हूँ. That you must discourage them from doing. The word is exclusive breastfeeding, and a lot of mothers propagate this advice: give formula once or twice so the baby बाद में लेगा. So such kind of advice you should protect them from. I preemptively explain to the mothers what the word exclusive means, so that they don't do such things.
It's an interesting question from Dr. Anupama Sharma. So if the mother comes to the OPD around 2 weeks with predominantly formula, this is a practical point.
Yes. So we face this all the time.
Yeah.
And there, I think the lactation concern must be involved. I slowly tell them the importance of breastfeeding. We check their supply. Many times they have sufficient supply, which they don't know. We check the latch. We give them galactogogues. And I tell them that, okay, you are giving 75% formula. We are going to slowly change this. I give her a period of time. Over a period of time, I tell her slowly decrease the formula so she's not stressed. And I slowly scale up the breastfeeding. Even if she reaches 50-50 or 80-20, I'm happy. And if she's on a bottle, I tell her to stop the bottle because the bottle is on, then mother's milk is not going to sustain. So again, most of them cooperate, some of them don't, but I think you have to do the job.
When the mother has some complications during cesarean, breastfeeding is delayed, what can we do in those situations?
Okay, see there you may be justified in using a formula, and there are mothers in whom there is delayed lactogenesis. So we must be aware of that fact. In those mothers, you may allow restricted formula supplementation. I said a restricted, but you must tell the mother that once your supply is established, we are going to wean off the formula. So just ensure that she doesn't give too much, and she must be told that it's a short-term supplementation and we are going to take it off. So she does not overdo anything. HMF such a duration I can see is a question that usually is given to 2 kilos. Very few babies may need more than that.
Then can we massage with MCT oil?
Yes.
I think this is...
Yes, you can. One can do that.
Soil massage before or after bath. I think
it won't matter. I think most mothers will massage before the bath.
Before bath. After bath, it may not be done. Once the baby is directly breastfeeding, how to supplement? I think you have
Yes.
So you make take a little bit of a few ml of breast milk and mix it and give it. If HMF sachet is affordable partly, then can we give multivitamin also with that?
Yeah, what you can do is you can instead of 8 sachets give only 4 sachets of HMF, and you have to calculate. HMF also contains nutrients. So if you're giving anything more than that, do an individual calculation at least for vitamin A, vitamin D, iron, because you may end up with overdosing.
Pankaji, questions are pouring in.
Yeah. I think I can see that, but it's interesting, no? There's a lot of interesting questions. Please go on, sir. If you want, I can also take the questions if you are tired.
In between you also can take it.
Right.
You can take some answers also.
Director Jigesha has asked that there is loose motions. I think one must also know that newborns or breastfed may be having breastfeeding stools, and all stools may not be loose motions. So it should be watery stools before you want to give ORS, which can be given if it is really acute watery diarrhea. Isn't it, Dr. Umesh?
Yeah, absolutely.
Does expressing milk after breastfeeding help in increasing milk secretion?
Yes, because sometimes the baby may not have sucked completely. There could be some milk. So the more you empty the breast, the more your lactation is going to sustain.
I think the hide milk part, I think that part also has to be emphasized when you talk to the mothers, because if they suck for a few minutes and then stop it, they don't getting only the for milk, and they may not have proper weight gain. So this has also to be mentioned along with that.
And do you recommend any galactogog? Dr. Nilima Patil wants to know.
Galactogogs are given. They have a very good placebo effect as well. But the commonest galactogog that we use is domperidone. And the natural galactogogs like Shatavari are also given, but they really work as placebos as well. The mother knows she's taking something, she tends to do better.
Right. So I'm sure one precaution must not use metoclopramide, because that has got side effects and extrapyramidal side effects also. So I think a lot of us used to use it in past, but now the only galactogog which is recommended by Boston University is domperidone, and there are some studies on that also. So if you really want to use that. Dr. Jigisha wants to know that mother of twins, they feel that they need to give formula because it is not enough for both. Any comments, Dr. Umesh?
Yeah, what happens is that one thing that some twins and some mothers, you may allow restricted formula, but again, I say 80-20. And I have a lot of champion mothers who have breastfed twins for full 6 months, and they can do it. So you must tell them that you will be able to do it if you decide. But if you cannot do it, a restricted formula use may be allowed. Bottle strictly no. And our lactation consultant trains them in simultaneous feeding of twins. If they learn to feed them together on the breast, nothing like it. They save time and the lactation is very well maintained.
I think very important point, Dr. Umesh. I also tell them that twins baby should be fed together at the same time. Otherwise, what happens is one baby starts crying, you're feeding the other one, that baby gets bottle, and it will happen reverse way also. So if both babies are fed at the same time, then is a way to assure exclusive breastfeeding for 6 months. Dr. Dushyant wants to know, delayed lactation happens in how much percentage of mothers having normal delivery?
It is 5% only. So 1 in 20.
Right, not much. But the Supreet
question
Kaur wants to know
antibiotic intake.
Yeah,
Antibiotic intake in mother for not giving breastfeeding. I think it's not.
Yeah, so most antibiotics are allowed during breastfeeding. So just tell her that, just find out which antibiotic is on, and accordingly you can recommend. Most of them are allowed during breastfeeding.
Another, there's Dr. Rajesh Kumar's question. I think you have already answered. There is no need of 25 ml of milk. You can mix HMF in 5 ml. There is a question regarding evening colic. Dr. Umesh, you can say something about that?
Yeah, so colic, I must tell you that colic is something that's overdiagnosed. Every baby cries a little, somebody calls it colic. I've had babies on day 1 and day 2 crying in the hospital and somebody is giving them a colic medicine. So colic usually occurs after 3 weeks, usually in the 2nd month of life, occurs 2 or 3 times in a week. It doesn't happen every day. So mothers, every time the baby cries, they will put some colic drops. So that's not required. And you must tell them that colic is not a grave diagnosis. Colic is a minor problem. It's a day-to-day problem, and they're too focused on colic at times. So you must see to it that you treat it when it comes, and it is not something that the mother should worry too much about. I think Dr. Heram was written there about this lactation. Believe me, every time I attend a lactation lecture or a workstation, I myself learn a lot. So this is the need of that. I think Dr. Pankaj, you must keep one session on this, and I can help you.
Yeah, we can have a session, but what I feel is that the course needs more physical teaching, in which you need to demonstrate a lot of things, and has really a physical course, offline course rather than online course. BPNI does one for 7 days, and all our lactation consultants and residents, we ask them to do it on regular basis. But something a short course can be arranged, but it will not be a certificate course. It will be just a training
program. I think you can have a online program followed by a 1 day offline something like that.
We can plan something like that.
Something like that. It may be useful.
We can do that.
And one question is how long the express breast milk can be kept in the room temperature?
It is 4 to 6 hours. Some say 4, some say 6.
Rule of 4 hours at room temperature, 4 days in 2 to 8 degree in chill tray, and 4 months in -20 degree. So 4 is a good rule to remember.
Dr. Kapoor wanted the dose of domperidone as a galactagogue.
Yeah, the dose that's recommended is 20 milligrams 3 times a day. So normally people used to give 10, but most of our lactation consult gives a dose of 20 mg TDS.
Yeah, the next question also related that you have answered it. How to assure feeding is how to assure the mother whether the feeding is adequate?
Well, we tell them what is the expected weight gain and the urine output of the baby. So we tell them these are measurable parameters. Don't go on what you feel, because the mother-in-law keeps on saying doodh kam hai, baby is crying, doodh kam hai. So they use various parameters, and you must tell them monitor the urine output, which is very easy, and the weight gain. We don't send them 30 grams a day. I say 20 grams a day should be enough. So if you put 30, sometimes they fall a little short and they start doubting their ability.
Dr. Arvind's question is prescribing probiotics and zinc drops for babies breastfeeding having loose stool. I think having loose stool is a normal thing, unless it is very watery loose stools. You need not give anything. And I don't think there's any role of prebiotics in those situations.
No.
If we have to use formula, what composition formula we can use? I think it is a...
Yeah, so what we do is that if you're a preterm, use a preterm formula. When the baby reaches 37 weeks, we should switch to the term formula.
Dr. Arvind's another question is regarding what type of probiotic you use.
Yeah, so again, what we do is we refrain from using trade names, but anything that contains lactobacillus and bifidobacteria is the right probiotic. Remember, Saccharomyces boulardii, which is there in some probiotics, is not recommended, at least in the NICU. So just look
less
at
than 2 months of age. So even the leaflet of Saccharomyces boulardii says not to be used less than 2 months of age. It should not be used.
Up to what age baby we can catch up for breastfeeding if mother is having no milk output prior?
You can depends from mother to mother, but I think don't put a timeline there. Even if a mother takes longer time, it doesn't matter, but see that she's moving in the right direction.
That's it.
And maximize her milk output, and then you can support a little with formula, but don't put a time frame. It's not required. And encourage her at every visit. You talk positively and appreciate what the hard work she's doing, because again, motivation to sustain that encouragement. Don't scold and shout on mothers. It has a very negative impact.
Dr. Parneet needs the color of the stool. Usually the mother are concerned about.
I tell them green and yellow, all shades are fine. If it's violet or blue, you tell me.
And white also. If it is white also, we have to be careful.
That's a good one. What time of the day domperidone?
Prescribe diet.
It is
What
tedious.
time of the day domperidone? Yeah, 3 times a day, anytime before or after.
Prescribe diet for mothers to prevent cow's milk protein allergy. I think it's for the mother.
Protein allergy is something that is not so common. It is being common now, but one should not, when you are advising something, but need not worry about it. There are some mothers who are consuming cow's milk and their baby may develop some allergy, proctocolitis, and some blood in stool. But I think those are rare phenomena. One need not worry too much about it. And unless there is strong evidence, do not tell the mother to stop her milk, because a lot of doctors are currently doing that. There's a little bit of blood in stool. They tell the mother next 3 months, no blood products, no ghee, no curd, and mothers suffer a lot. So you should be very careful that we have sufficient reason to stop her milk.
There is another question: is there any good article on formula feed when we don't promote formula?
No, the issue is they should know what the formula in the market are, because many times these formula companies keep on changing the names and they're changing the content. So
so many modifications.
And newer things keep coming. So what happens is you must be aware of it. So all of us use hardly any formula or less formula, but we must know the market. And so I have a slide with me which shows which formula contains what. So that, and at least if you don't want to go through a content, see that the preterm is receiving a preterm 1. First 6 months, your stage 1, next 6 months is stage 2. And do not switch to hypoallergenic formulas and elemental formulas unless there is strong reason, because these are very expensive. So sometimes I see people just say, stop this, put on soya formula, put on low hypoallergenic formula, and people spend a lot of money on that. So you must be very careful when choosing your formula.
I think one comment I want to make it here. I think we have an LBW formula. There's nothing like a LBW formula globally available. So I think you should have a term baby formula and a preterm baby formula.
Correct.
So LBW formula is the preterm baby formula. Yeah. If you have a term baby who is 2.2 kg, please give them a term baby formula and not LBW formula. So that is one thing which is very peculiar to our country, which we have to defend.
How long you should give domperidone as a galactago? How many days?
Usually 1 week is enough, but some mothers can take it longer. Sometimes you can even give it for a month or 2. But usually I give it for a month. Once lactation gets established, then it goes on to autocrine control, where it is established by sustenance of suckling. So you don't need the galactago for too long. But some mothers are psychologically dependent on it. Then we continue. But normally a week or 2 is more than enough.
Next question.
Yeah, please go ahead.
Yeah, by Dr. Amit Sume. I think we have mentioned that perinom, that is metoclopramide, we are not using, and herbal product Satavari has just a placebo effect. I think we have mentioned that. I don't know. This is can we start breastfeeding in a mother already on levetiracetam?
Yes, I think she can.
Then Then Dr. Arvind's question is, some mothers say even after feeding adequate quantity like 60 ml, some say taking 90 ml still expecting more milk. What is the maximum amount we can say to feed, especially in the first
There
month?
is no maximum amount. We say ad-lib feeding. Ad-lib feeding as much as the baby takes. So we
I
do
think
not
this is the ml is calculated by when they are giving formula. Otherwise, how can you say that it is?
Yeah, but even there also, if you formula, also have to give as much of the baby takes.
Yeah. I think how long? I think domperidone you have already mentioned. How long we can store breast milk at home for working mothers? This is a very pertinent question. Express EBM. You said, you already said, no?
Dr. Pankaj answered that question.
I could not get it. What's the question?
No. Regarding keeping EBM when in the
Yeah. I said that you can use it 4 hours at 25 degree, 4 days if it is 2 to 8 degree, which is fridge, not the freezer, and 4 months if it is minus 20 degree, which will be deep freezer in the unit.
And another thing is that if it should be warm to the room temperature before giving to the baby. That is also
it should be kept in the room temperature. You should not use any warming thing. It should be left to the room temperature and use.
Yeah. Should we withhold breastfeeding during acute gastroenteritis during in 6 months of age?
Absolutely not.
No.
How to warm breast milk if we need to give it once the working? I think it is no warming. You have to keep it in the room temperature and make it up to the room temperature. We have some formulas promoting they have HMF. I think probably it is HMF. Any update?
Yeah, HMOs, most formulas now have HMOs, they have human milk oligosaccharides, and there have been evidence to show that they help. They help in immunity, they help in brain development and sicknesses. So if at all you have to use a formula, use a good formula which contains HMO. There have been shown to be benefits. But remember, the formulas have limited number of HMOs. Mother's human milk has more than 200. Formula has only 3. So again, mother's milk completely outscores the formula.
I think Dr. Dushant Rastogi's question is, some office goer mothers express their milk 2 times till evening, and that is fed throughout the day while she is out of the office. Is she breastfeeds after evening? Is it okay?
Absolutely okay.
Another question regarding the anticonvulsant mother on phenytoin, phenobarbital. Can she breastfeed?
I think yes, you can breastfeed. There are certainly guidelines. You just follow them. So there are medications in lactating mothers. I think this mother can feed, but whenever you're in doubt, please go to Lactamed. Lactamed is a site which tells you clearly if you can feed or not, and if there are any adverse effects. So check it out, because it's not possible for us to remember each and
yeah, right. Can EBM should be stored in a glass or steel vessel?
So I think that what they explain and what's the best is polyvinyl plastic. That is the best way to store it. But if you are going to do it very short term, it won't matter whether it's glass or steel.
How to explain mother while stopping breastfeeding at the age of 2 years?
Yes, that's a difficult question to answer. But what I do is I tell the mother that let the child start sleeping with the grandparents off and on. And finally, when she wants to wean off for a couple of weeks, the child should sleep with the grandparents if they're available. But that will actually help this lactate. The mother handles the baby at night. It's very difficult. The baby will keep on crying till she feeds. So just the mother has to sleep away from the baby, and grandparents are a great help at that time.
And Amit Sir's question is how to educate and tell while recommending a breast pump.
Yeah. So as I told you, first decide whether you want a manual or electric pump. Look at the costs, and the brands that we have in the market currently are very, very standard. You've got Medela brands, then you've got Pigeon brands. So you have to just go for the standard brands and just find out what is the purpose of the pump. Do you need a manual simple pump for short-term use, or you need an electric breast pump? Always prescribe a pump which is around 5,000-6,000, which most parents can afford. There are pumps which can go nearly for 1 lakh. So you have to be a little careful.
Dr. Pankaj, it is 10:30.
Yeah. Just 3 more questions left. I think we have promised to the delegates that we'll take all the questions.
Okay, then you just take it. I have a call. Please take it.
No problem. If mother is zero positive, is breastfeeding safe for formula feeding? I don't know what is zero positive. Maybe they're saying zero size or nothing. But I could not understand the question well. Breastfeeding is safe anytime, right, Dr. Umesh?
Yes.
Zero positive. I think he wants to say zero positive for what? So even if it's HIV zero positive, now we have FSSA guidelines then what to do for. So that is a separate session. Mother or anti-diabetics can feed? Short answer. Mother on anti-diabetic drugs.
Again,
Baby.
I told you that most mothers can, but please check it out on the site because brands are different. Sometimes you have combinations, different doses. So better to check it out before. Don't leave it to the physician because physicians casually say "Band kar do." You should actually check on the LactMed website and then decide.
Should we suggest mothers any medication like clopidogrel to stop breast milk?
No.
I think no, we don't do that. We don't recommend that also. Baby remains away from the mother, especially if you're talking about 2 to 3 years old child. If the baby is not sleeping with the mother for 2 weeks or so, breast milk will start coming down. So we don't recommend any medication. Some mothers are asking to prescribe medications or cream to stop breast milk as child is not stopping even after 2 years. So we don't recommend medications, as I said. Right. Last, Dr. Amit Swali's mother had adequate vitamin. Will her breast milk will be adequate in vitamins?
Yes, it will. It should.
Yeah. So I think we have 72 questions, Dr. Umesh. That's the success of this program.
Absolutely.
You can see that people ask so many questions that it is equivalent to your session. Your session lasted 50 minutes and question answer has already lasted 40 minutes. So I think if there are no more questions, I'd be very, very happy, very excited that today's session was one of the best which I have seen so far. So many questions and very, very patiently answered by Dr. Umesh and a lot of inputs from Dr. Ashok on this. So if everything is fine, I'll thank Dr. Ashok and Dr. Umesh for the nice presentation. And we are all committed to take care of newborns of the country so that we are able to do better in all our indices, because now we know that under 5 child mortality, morbidity, everything is related to neonatal issues, neonatal mortality. So we are all committed to do that, and that is why IIP Delhi has taken this initiative to take neonatology to a far ahead level. And I'm sure when this course is over, we will be taking ahead another advanced course of eNeo course also, in which more core issues of neonatology also will be discussed. So with these words, thank you so much. Namaskar.
Thank you, Umesh.
And we see you with another important session next time, which is a surgical newborn. How to deal with surgical babies in neonatology by Dr. Satish Agarwal. Next Sunday, 9 o'clock. We'll see you again. Thank you so much.
Thank you.
Bye.
Good day.
Bye.
Good day.
Bye.
And this session will be available recorded format in your presentation very soon. With 24 hours in WhatsApp group, we will load the recorded session. So you have missed something, you can again listen to it. Thank you so much.
Thank you. Bye.
All right.